So, Doc, other types of modalities that we could use. I know night guard is always one that a lot of people talk about. I'm just curious, are you for it? Are you against it? Where do you kind of come from when you think about using a night guard?
And is there a thickness that you look for too with night guards?
Yeah.
So we're pretty much going to want to let the dentist control that.
100%.
The main thing you want to have the patient communicate with their dentist is that dentists are always thinking teeth, 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 right? Not always jaw. So the dentist may want to put them in something to protect the surface of the teeth because that's their priority, protect the teeth from the clenching and grinding. We, as TMJ clinicians, want the dentist to put them in something that's going to create a bit of a gap in the back molars so that we don't have good contact. It reflexively inhibits your body's willingness to clench the jaw at night because your brain senses we don't have good bite contact. And so it is unsafe to put force through the teeth.
Okay.
And so they used to have these really small ones. They're called NTI. I can't remember what it stands for. It's like neurologic trigeminal inhibitory thing, but it's a little one that went just across your front teeth, makes your front top teeth and your front bottom teeth touch earlier than everything else.
Okay.
That gap keeps you from clenching. However, the uneven bite force over time will cause shifting and planing, deplaning of your teeth. So then they switched to an ABP splint. That's still something that I recommend, although some dentists don't like it, mainly for the teeth alignment reasons. But anterior bite plane splints, ABP splints, they go across pretty much the whole front row of teeth, and they make those teeth come into contact while the back molars cannot. So there's a bit of a lip there. It forces the patient into a slightly open position. And again, the brain doesn't want to clench down because it can tell there's an unevenness between the back and the front of your teeth. Then there's full contact guards. Some of them can be designed with a bit of a lip so the front teeth have higher, and it does the same thing with the back molars of gapping them. Some of them are flat though, and when they're flat, what ends up happening is you just have a new plane and you clench and bite down on that plane. And so when you have a night guard like that, you tend to clench and grind more because now you have something protecting your teeth. You have the ability to push harder because of that protection. Now, that's less likely to happen with a prescription night guard from your dentist, which is what I recommend. Okay.
Yeah, 100%.
What you don't want to go do is go to Walgreens or Walmart and go get just an over-the-counter night guard.
Yep.
These thin, rubbery night guards, those are also just designed to protect the surface of your teeth.
Yep.
But they're not designed in a way that has any custom approach to you and your bite. And so what your body will do is go, okay, something soft in my mouth, crunch, 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 grind, grind, grind. And you'll know it's not working for you because you take that night guard out in the morning and it's shredded, right? If it was stopping you from clenching and grinding, it would not look ruined in the morning, right? And so when you have a proper night guard, those dental night guards, not only are they more robust, they're going to last you longer, but they can be designed in a way that helps inhibit some of that clenching. And that's one of the primary drivers. So 80% of TMJ is myogenous from overactivity of the muscles.
Yep.
Most of that overactivity comes from nighttime clenching and grinding, although sometimes daytime clenching as well. And the night guard helps to counteract that. So for many patients, that may be all they end up needing, right? Maybe they need a visit once every month or two just for a little adjustment on the jaw just to help them on their way. But a lot of times the night guard can knock out a huge majority of this. Now, you're also going to have tons of patients that come in to see you once you get a reputation for treating TMJ. Yeah, I've been to the dentist. I have the night guard. Yeah, I went to the medical doctor. I have the muscle relaxers. Yeah, believe me, doc, I've done everything, right? And that's when we got to dig in a little deeper and see, okay, what is it that's driving this?
Sure.
I think people are starting to realize that teeth and jaw can kind of go and work hand in hand. Have you seen cases, or I guess, what is your thought process through certain cases of maybe a tooth extraction on maybe a molar wisdom tooth on one side, whether they had TMJ dysfunction prior to, or that's the thing that set it off? Where does your mind go clinically wise to get under control? Obviously, there's like an assessment portion, but I guess how big of an impact can this have on some people?
So if the teeth are not coming into alignment correctly, it has a tremendous impact. So what your brain is essentially trying to do, if you have a high spot on a tooth, so your bite is uneven, right? Let's say whether you had a dental procedure or not, your bite is uneven. Mm-hmm. Your teeth have the enamel coating. They're made of a certain type of bone, and you can wear that down by grinding them. You can wear down the surface of your teeth. And so what your brain is trying to do is it's trying to take a high spot where your bite is not coming together right and it is trying to grind the high spot down and fix it at night. Now, where you run into troubles is you get a crown or something, or a filling on the top of your tooth. So now you have an artificial tooth surface that's not made of enamel and cannot be ground down. If the high spot is on the artificial tooth surface, no amount of grinding is going to grind that down.
Right.
What you can do if the tooth above it or below it, whatever the opposing tooth is natural, is you can grind the opposing tooth until you create a pocket for it, and then that will resolve the issue while ruining your tooth.
Right.
Where you run into real big issues, and dentists are pretty careful about this, so it's not very common that this happens, is you have a crown on top, crown on bottom, same tooth level, like row. I don't really know how they number them. Now you have artificial on artificial. You are never going to be able to grind those down. So if you have bite that is not lining up properly on two artificial tooth surfaces, you will theoretically clench and grind forever. Most people do eventually end up breaking or cracking their crown or their filling, and that's how that happens. Now, dental procedures in general, oftentimes, especially for the back teeth, like the molars, wisdom teeth, things like that, they are low-grade trauma, sometimes even higher-grade trauma. And again, trauma can either be high intensity, short duration, or it can be lower intensity, longer duration. So if you have a 4 or 5 hour dental procedure that you're undergoing, that is a lot of trauma on the jaw, or keeping the jaw open that long. Maybe it's even just a 2-hour dental procedure, which is not that unheard of, but that's still quite a bit of aberrant stimulus that's going into the jaw. And so those can also contribute to starting this cycle, right? So, the same way that a sustained posture at work over your keyboard,
yes, 100%,
can set off neck and upper back pain, a sustained dental procedure with prolonged opening can set off the cascade that then leads to jaw pain.
Yes.
So, dental procedures can cause it, dental procedures can fix it, right? So if there's a dental cause to your pain, you want to see a dentist. If it is a musculoskeletal cause to your jaw pain, then you want to see somebody like us, a physical therapist who's trained in TMJ, a chiropractor who's trained in TMJ, are going to be able to figure out what's going on and get you on the right track to helping you. But so the teeth are incredibly important, and I would not recommend, this is one of those things, like, you could specialize in the shoulder and maybe not have other shoulder specialists from other professions involved in your practice and probably get away with it, pretty well. You cannot really treat the TMJ and not have the dentist involved, at least a little, right? Either involved on the front end or involved on the back end. So if a patient comes to see me and we're not succeeding and they don't have a dentist, we get them into the dentist.
Yeah.
Even if we are succeeding, we get them into the dentist for that prescription night guard. Now, if they've gone to the dentist, they've done the night guards, they've done all that, and the dentist is not succeeding, then they come to us. Now it's our turn to do our job. But we really want to have that close interplay. Because the other thing is, as you start to assess patients' jaws, you may notice as you're asking them to open and close, like I'm looking down into their mouth. I may notice wear on the tooth surfaces. I may notice cavities, color abnormalities. Now, I'm not trained in dental structural assessment, but I can go, hey, that looks like you've worn down your tooth, right? Let's have your dentist look at that and see if that's part of this as well.